recommended pretty much for all the children. Because as we know from careful studies, there are some learning problems just in adults, and some of the kids even with Alzheimer's. So that should be the normal routine. We don't have a treatment paradigm based, and I'm aware, we don't have a treatment paradigm based simply on poor school performance for an intervention such as hydroxyurea or certainly transfusion. However, within the next year, I guess the results of the silent infarct trial will be out. This, as you know, is a study that is a randomized comparison of transfusion and no transfusion in a group of children who have abnormal MRIs, but who do not have abnormal TCD. So if they had an abnormal TCD, they were taken out. But if they had a conditional or normal TCD, then they were randomized. And the endpoint is, of course, clinical stroke and more MRI lesions. But we'll have to see what that shows, and if I'm sure they have some behavioral component there. Regardless of what happens to the MRI, if their educational performance improves substantially on transfusion, I think that would be a very interesting finding. I sometimes wonder about these tests, the testing that we do, and about how does a child perform in the environment with only 60% of the hemoglobin that they should have. I'm not surprised that they're not enthusiastic about the testing or about school or anything else. So I believe that you probably get better results after 3 months of transfusion, just because they feel better.
Nós temos atualmente estudo que está sendo conduzido aqui por uma psicóloga da UFMG, junto com o professor Marcos Goulart, que esse trabalho está avaliando crianças maiores, porque está sendo feita a ressonância magnética e testes psicológicos e o Doppler. Mas também o trabalho está no início, mas são crianças maiores. Porque o background, André, ele é de crianças menores, né? A Jude falou pra gente, né? Eles começaram a criança de 7 meses ela fazer o Doppler. Então fica difícil fazer a avaliação. Mas esse trabalho está sendo conduzido com crianças acima de 5 anos, né? Também, como o professor Adams falou, esse outro lá, né? Pode ser que a gente tenha alguma resposta, né? Também. Mas
pela apresentação. Celinha, na sua apresentação você mostrou que você tem 19 casos de crianças que estão fazendo transfusão e que mantêm elevadas velocidades. E nesse caso você associou a hidroxiureia. Essa associação, você já tem algum dado no sentido de se isso leva a uma redução dessas velocidades?
Sim, Eustáquio, nós ainda não quantificamos esses dados, mas a gente, assim, no nós realmente a gente percebeu que muitos pacientes respondem. Agora, alguns não respondem. E aí que a gente fica naquela história, será que realmente a doença já é tão grave que nem transfusão de hidroxiuréico adiantaria? Mas alguns, a gente tem alguns que eu tenho especificamente uma paciente minha, que até a semana passada ela fez o Doppler, ela tinha alto risco, mantinha com alto risco, depois de 1 ano de transfusão, associando hidroxiuréia, ela passou para risco condicional tá? De alto risco para condicional.
Mudar um pouquinho para adulto. Vocês estão falando de criança. Eu tenho alguns pacientes que estão fazendo AVC agora em adultos, com 24 ou 28 anos. E a minha preocupação é iniciar a transfusão, eu estou fazendo, mas eu sei que não existe um consenso a respeito. E, em geral, eram pacientes que já estavam com hidroxiureia. E aí eu não tinha hidroxiureia, eu inicio a transfusão e mantenho a hidroxiureia. E eu estou tendo muita dificuldade nesses pacientes com a hemoglobina. Eu estou precisando fazer sangria porque eles têm mantido a hemoglobina entre 9, 10, 11. E eu tenho que sangrar porque senão eu não consigo transfundir. E aí eu fico pensando, se vale a pena parar a transfusão e ficar só com a hidroxilé, já que está mantendo a hemoglobina tão alta. Você me faz uma ajuda.
Well, I might appeal to the audience here, see whoever's working in this regard. I don't, we might, because I'm a neurologist, but I haven't seen a lot of dual use of transfusion and hydroxyurea in the United States, except to transition between transfusion and hydroxyurea. You know, certainly when it comes to the recommendations for adults with stroke and sickle cell disease, you have to decide, you know, is this an adult who happens to have sickle cell disease, or is this a sickle cell patient who happens to be an adult? The approach seems to be very different, but there's certainly no reason why you wouldn't take an adult with sickle cell disease and stroke and apply the guidelines that we have for general stroke prevention, which typically are an antihypertensive, even if they weren't hypertensive, an antiplatelet agent, almost certainly a statin. Depends on if these patients may have very low LDLs already. I don't know how much we know about. How much do we know about cholesterol in sickle cell disease adults? Are there any data? You know?
Não. Eu não tenho muito nada assim. Ela não tem hipertensão, não tem nenhuma outra causa. A causa foi a AVC mesmo. E quando eu parei a transfusão, ela teve outro AVC. Mesmo com a IREA. E aí, só que eu estou tendo uma séria dificuldade para transfundir agora.
Eu acho que é uma dificuldade para todos. Eu não lido com adulto, né? Mas a gente está na prática, no dia a dia, a gente está vendo também. O que eu acho é que a gente precisa estudar mais mesmo. A gente, numa hora dessa, a gente usa o que a gente tem. E eu acho que a gente precisa de estudos mesmo maiores, com maior número de pacientes, para a gente criar os nossos protocolos, né? Porque já que tem, tentar estudar. Né?
Yeah, let me add to that and say that one of the things I didn't mention, I talked about the importance of funding for the trials and everything. But there is a way, perhaps you're already doing this, but there's a way to start off immediately that is very relatively low cost, and that is to enroll all your patients in observational cohort studies. And these simply require the consent to follow the patient. And patients always sign this, and they never refuse to do this. All you have to do is promise to protect the privacy of their records. And this is why this is very important, because number one, you have a systematic record that you can pool the experience, and even though it's not a trial, it's at least something. And in a data-free zone, something is better than nothing. The second thing is that, as was pointed out by many speakers on the first day, this is a big state, and the patients you may see patients regularly, but in between time they go to other places. You have to have the permission to have your medical students or your postdocs go after that information and bring it into the data. That's why you need them in the cohort study, so that you have the permission to go to the local hospitals or whatever else you have to do to get those data, so their hospitalizations that occur outside of your place are part of the record. And then you develop simple data sets, not complicated data sets. These become really more like registries than data banks, because data banks can be overwhelming and frequently are not worth all the work. But a registry, simple registries where you have some basic information, I think could be very valuable as you go forward.
I have a comment and also a couple of questions for Dr. Adams. Regarding the double use of hydroxyurea and transfusion, in the United States, we basically do not do that, like Dr. Adams alluded to. Mainly we do that in the transition process between chronic transfusion to hydroxyurea on a study or in our clinical experience if the patient has significant iron overload, if the patient has developed antibodies, and it's basically possible to transfuse a patient, and we do transition them to hydroxyurea. I have a patient that actually are using double treatment. This is a particular patient that I have with hemoglobin SC who actually had a stroke. And because of problem with IV access, I do transfusion with partial phlebotomy, and I also give hydroxyurea with some increase in the fetal hemoglobin. So I'm doing that, and this is, my personal patient, but of course, this is not as part of a trial. I had a question, actually a couple of questions for Dr. Adams. One would be the age of screening based for TCD. Based on the STOP study, of course, we say 2 to 16 years of age. In my personal practice, I actually only screen up to age 10 because the majority of patients do develop strokes during those ages. But I wonder, maybe I should continue to screen. Maybe we should continue to screen all of our complications based on this new emerging data about maybe the use in adults would be good. Of course, we don't know what the cutoff is, but if we don't observe it, if we don't screen that, we will never find out. So I want his opinion on that. And secondly, it's a question that I asked before to you, but if you could comment on the low velocities, you did not mention that in your presentation.
Thank you. The question about the screening, I would continue the screening yearly all the way through into early adulthood if you can. I think this could be part of a protocol, but it wouldn't have to be, it would not, in my opinion, be an experimental procedure, given the fact that there's enough information out there to easily justify continuing to do it. We do so many tests in medicine in the United States for which there are no really firm data on the clinical utility. It's pretty ludicrous not to do a simple study like a TCD all the way on through, and we don't know what we may find. My own experience is there are a few cases presenting like typical pediatric vasculopathy when they're 18, 19, 20. They just show up late. So there aren't many. But once you get them used to it, I see very little resource cost to just continue to do it as a routine. If you have a velocity that's very low, particularly in a focal manner, and the number we've used is 70 centimeters a second, this is for a child with SS disease, not SC. We don't really use TCD and SC, but we're beginning to try to look at that. I think a low velocity requires some investigation. There's certainly a number of reports. A low velocity can be either a poor technique or it can be an abnormal vessel, severely defective vessel. If you make a couple of passes with your TCD and feel confident that you're getting, that you have a consistently low velocity, then I would follow it with an MRA. And even though we don't know how to choose people with MRAs, I mean, a bad MRA can't be good. You probably need to intervene. If you don't have good TCD markers, you have to go with what you have. Like when you can't do a TCD, a bad-looking MRA is probably a bad-looking future. You have to go on that, even though it's qualitative, whereas TCD is really more quantitative. Now, Amelia, I want to ask you, who is your adult counterpart at University of Miami, and what do they do with vascular disease problems?
It's Dr. Thomas Harrington. I don't think he does TCD screening.
What about when they have symptoms, though?
Well, he will get a brain MRI and an MRA.
But treatment?
Transfusion.
He'll do treatment.
Yeah, he does do transfusion.
But it puts them in a regular program just as long as they'll stay in it?
Yes.
I think that's the thing to do. Have any idea about recurrence under that situation?
No, I don't have that.
What's the name of the person?
Dr. Thomas Harrington.
Does he go to the sick meeting?
Sometimes he does.
Does he? Okay.
Yeah.
I'm in.
Okay, sure.
Doutora Adams, gostaria de ouvir a opinião sua a respeito
children who develop moya-moya, I would put them in a careful transfusion program. I follow moya-moya disease, in my opinion, can only be followed clinically and with MRI. The reason I say that is you cannot interpret TCDs or the MRAs once they develop moya-moya. They're crazy, they're all over the place, and they're not interpretable. The only thing you can do is ask yourself, is this child losing brain? So you do put them on the program and you do frequent MRIs, and if in fact they're losing brain tissue, you know, whether they're having symptoms or not, it doesn't matter to me. All brain is important. Then you have to consider surgery, and the surgery, of course, is unproven and probably never will be subjected to a trial, but still, most big centers have surgeons now that are comfortable doing these procedures. They're not, strictly speaking, bypass procedures. No, what they do is they just take a vascular pedicle from the muscle or something that's supplied by the external carotid system and just basically get through the skull and the dura and lay it down, and the brain does the rest. The brain will, if it's ischemic, it will ask for angiogenesis, and it will develop then as a blood supply. There are some examples in the adult world where people have occluded their carotid arteries and have collaterals from the external that go through the eye, they go through, even they go transdural sometimes. A few famous cases where people have been shot in the head and the vessels use that hole to get it and feed the brain. So the brain is pretty clever about getting blood if you give it a chance. Are you doing these procedures here very, very much? They call EDAS, they have different.
Nós temos alguns pacientes que no Hospital das Clínicas e no outro hospital, o Hospital da Baleia, que a gente chama, que tem dois neurocirurgiões que têm experiência e, inclusive, nós tivemos uma criança que tinha uma moia-moia muito importante e estava repetindo muito os eventos após fazer, mas eles fazem a temporal, um bypass com uma temporal. E falou, essa criança cessava pelo menos os mais expressivos, né, eventos.
Well, I would, in the absence of data, I would do it. But I would probably keep them on transfusion for a long time afterwards as well. And you know, again, once you get to the moya-moya state, your options are not very good. We want to keep them from getting there. And of course, as all of you know, occasionally children without any known disease show up with moya-moya. And we have the same problems with those, or neurofibromatosis, I think, has moya-moya, and some other diseases that are not related to sickle cell disease, but it is more common in our disease.
Bom dia. Eu sou neurologista, eu faço doutor em primário em adulto. E agora estou acompanhando a doutora Célia nos doutos em crianças. A minha pergunta seria, num paciente que não tem uma janela adequada, claro que criança é muito menos do que adulto, mas nesses pacientes, vocês fazem uma insolação temporal contralateral, utilizam janela transorbitária, e parece que o contraste também não é feito nas crianças com Falciforme, nem a gente usa aqui no Brasil, mas ou já partem direto para a transformação.
Okay, the question is a good question, and let's say you're talking, this is an adult with sickle cell disease, or just any adult? With us today. Yes, as you point out, you can clearly get useful intelligence from the other side with that proper technique. You cross the midline, and if you can interrogate the middle cerebral artery on the other side, then that's fine. You don't need anything further. And yes, by all means, do the transorbital. The reason we decided not to do the transorbital a long time ago in children was not because the transorbital does not have value. It does have value. You could argue that for sickle cell disease, it's the very best approach because of the location of the disease. It's just that we made the practical decision that we did not want the children to associate that junk in their eye with the test. It's like a lot of things in life. You have the choice between the better of a lesser thing or the lesser of the better thing. So doing the complete examination would have been the better thing, but it would have been lesser because we would have lost so many kids. So we decided to leave it out. But adults are different. Now, you can talk them through it, and the older teenagers might. Absolutely, that is a great place to go right after the pathology. So you could argue that even that if you did a good transorbital, you probably don't need anything else. Because the probability of the disease is going to be in the distal ICAs. And you know, without any other indications, I'm not sure you would cover it. Although, having said that, I would justify to any insurance company that a patient with sickle cell disease needs an MRI and MRA simply because of the prevalence of the disease. Say, I think you guys should pay for this because, you know, at least if we knew ahead of time, maybe we could do something. So, you know, that's kind of my answer.
Eu só queria completar, dar uma olhada no trabalho da Gisele de São Paulo. Ela estudou 86 adultos e mais ou menos o mesmo número, 100 anemia falciforme. Ela só não conseguiu janela em 2, um de cada grupo. Se você quiser, depois, tiver dúvida, eu posso tirar o e-mail da Gisele, que é neurologista, e você pode começar a melhorar com ela.
Eu queria saber se existe algum sinal de gravidade ou algum critério para a gente poder indicar o Doppler ou tentar fazer o Doppler transcraniano em crianças menores de 2 anos de idade.
I think the argument for there are no criteria. I think the reason for doing it is so that you can detect early cases. So I would start when they're 9 months, whatever the earliest you can. I think our guidelines should be changed because we simply picked 2, as we thought 2 was a practical lower limit, but as Judy showed, it's not. And I think we would be better off, as you heard, there are these rare cases of progressive disease early on. So I would start at around 9 months. You should see 6 to 9 months. You should see the normal progression of velocity changes in sickle cell patients that you see in normal patients, which is it's basically, it goes up for a while and then it'll go down if they're normal. It goes up in early childhood because it's actually lower in the newborn state. So as they change, they will developmentally change because of the brain requirements, and they will also change developmentally because of hematologic change. So you'll be able to follow all that. The developmental change of the brain is simply guessed by the age, but the hematologic change you'll get from your CBC. So earlier the better, I think. Every one of them.
Difícil é fazer, mas como a Judy já disse aqui, se a gente tiver paciência, repetir 1, 2, 3 vezes, a gente consegue, né?
Bom dia, eu queria agradecer à mesa pela brilhante apresentação dos doutores, mas a minha pergunta, eu sou hematologista e mexo muito com adulto. E com o passar da idade, essas crianças vão chegando à adolescência e à vida adulta. Essas crianças que apresentam o Doppler transcraniano alterado. E vocês mantêm o regime de hipertransfusão. Eu sei que cada caso é individualizado, tem umas particularidades, mas mantém a hipertransfusão e que nível de porcentagem de hemoglobina S vocês alcançariam? Até 5 anos, 30%, 30%, 40%, após 5 anos, 50%, ou naquelas pacientes com doador na família, encaminharia para o transplante de medula óssea.
Excellent questions. I would say if I identified an early childhood case with a high TCD, and they had a donor, I would probably consider transplant. Just and I'm now speaking as a father, not as a doctor, okay? Because I really don't have to make this decision as a physician, but I'm imagining what would I do if I were a parent, knowing what I know about the course of the disease. I would certainly take a 3% mortality risk. I don't know if I would take a 5%. It's got to get pretty low before you take that risk for an existing a live child, and you go through an ablative marrow transplant. If they had a non-ablative approach, it would be better. But in any case, that's most of the time you won't have a good match. The target, I think probably anywhere from 45% is probably fine. And I would probably, just based on what I've seen, I would say anywhere between 30 and 45 going forward as a practical approach. You'd be better off in the long run because you won't have quite as much iron and you'd be able to manage them. And I would keep them going as long as I could. I think since we don't know, I wouldn't, if it were me and it were my child, I would just say, let's keep on going, just manage the iron. Because I think the infection risk seems to be virtually non-existent. It's really an issue of iron. And as the STOP study showed, it was the first randomized trial of transfusion. I mean, I was sitting here yesterday trying to figure out, and I wish Roberto was here, but I guess he had to. I'm trying to think I don't think in STOP we had any signal of harm in any domain. We did everything we looked at was better on transfusion. From silent infarction, pain, to chest, every single thing we looked at was better on transfusion. I sometimes think if I had a child with sickle cell anemia, I would get all my relatives together, put them in a room and say, you're not leaving till you donate blood, and you're going to do it every month for the rest of my child's life. But I don't know, that's just me. And again, I'm speaking not as a hematologist, but not a hematologist. I guess knowing what I know, and knowing how, theoretically, how we can manage iron. You guys know how hard it is practically. I only know what I hear, but with the chelation agents, etc., I think managing iron, I would rather have the iron problem than have the brake problem.
Uma outra dúvida que eu também tenho é com relação, não foi sobre essa palestra, não falou, mas sobre o AVC hemorrágico nos pacientes. E é muito difícil, é um dilema que a gente enfrenta com o envelhecimento desses pacientes, né? Mesmo adolescentes, adultos jovens, apresentando AVC hemorrágico. E no caso, a transfusão estaria indicado, qual seria a melhor conduta?
Well, I looked at this a long time ago, and I'm not talking about subarachnoid, intracranial hemorrhages. Of all of the reported angio cases, half of those people had occlusive vasculopathy as well. So some of those patients have both problems, and those I think would benefit the transfusion. The subarachnoid hemorrhages are a weird bunch. Some of those don't have anything, as you know. You do the angiogram, it's probably some sort of venous bleed. They probably don't need anything. They probably don't have any additional risk. Somebody with aneurysms, they need to be fixed. Of course, those are easy things. The rest of them, I guess I'm curious, what's the reason you think, why do you feel sure that transfusion wouldn't be helpful? As opposed to we don't know if it's helpful.
É porque nós não temos uma literatura definindo o tratamento, né, desses pacientes com transfusão, principalmente adultos. A gente não tem estudos com relação a isso. Então, talvez associar hidroxiureia seria
uma alternativa?
I think a lot of people in the United States would choose hydroxyurea. A lot of people would, simply because the adult physicians, it seems like hematologists, aren't very keen on long-term transfusion in adults with sickle cell disease in the United States. So I think they're anxious